started. So good afternoon, and thank you everyone for joining us today. Welcome to the BREE Collaborative and Fletcher Group webinar, Addressing Health Through Housing and Employment, Aligning Funding to Achieve Outcomes. This is a follow-up webinar to the one that Milena Stott of the Fletcher Group and I put together in February, which was on building recovery ecosystems and collaborative approaches to health and housing. I'm Amy Etzel, Implementation Manager with the BREE Collaborative. Before we begin, just a few sort of housekeeping announcements. As a reminder, you are all currently on mute and you will be throughout this webinar until after our presentation. We would love your participation in some polls throughout the webinar, as well as a Q&A portion at the end of the presentation. We will be utilizing the Q&A box to facilitate this discussion, so feel free to enter questions at any time during today's presentations. We will also be monitoring the chat box, although mainly for technical issues, we'll be looking at the chat box, and then for actual questions, we'll be looking at the Q&A box. This webinar is being recorded. I'll be sending out a link to the which is the recording of today's events and a copy of today's slides sometime before the end of the week, along with some relevant resources that will be discussed. You may have also, actually, no, I forgot to turn on the closed captioning. So I'll do that after my little participation in housekeeping. But for now, I am going to turn it over to Melody Pizoltz and her team, Section Manager with the Division of Behavioral Health and Recovery from the Healthcare Authority. So welcome, Melody.
Thank you so much. I appreciate the opportunity to be here and introduce a few of my team members that may be on the call today. So we are part of the Healthcare Authority, managing the Foundational Community Supports Program. And so we have Don Miller and Darren Paschke from the Healthcare Authority. They are our supported employment trainers. Don is located on the east side of the state and Darren's located on the west side of the state. We also have two supportive housing trainers and program managers. Kimberly Castle is our West Side trainer, and Amanda Poley is our East Side supportive housing trainer. And then we have our administrative team that manage the FCS program, Lisa Gosiaco and Matt Christie. Matt is the program administrator and Lisa is the program manager. We also have our partners, research and data analysis. Taylor Danielson will be sharing the evaluation results, and Tori Kanda from AmeriGroup, our third-party administrator partner in the program. So we're very excited to be here today and share information about social determinants of health and an introduction to foundational community supports. Let you go ahead and launch the polls. We'd like to start and learn from you just kind of a understanding of the need for supportive housing and supported employment.
Give me one moment. I had to move a few things around and now I've lost the ability to find the polls. There it is. Okay.
Technology.
Indeed.
So we'd really like to get your perspective of what you think the employment rate for people receiving outpatient mental health services was. I'm going to provide a little bit more context to this and just thinking about that before the Affordable Care Act, before Medicaid expansion. So before 2014, what do you think the employment rate was for people with receiving outpatient mental health services was?
So we'll let this go for about another 10 seconds.
Great.
Looks like it's slowed down, so I think I'll end it now.
50% of folks thought it was between 0 and 25%. 25% thought it was in that 25 to 40%, and folks thought it was between 41 and 60%. So according to research and data analysis and through wage data from Employment Security, the employment rate for people receiving an outpatient mental health service in 2014, prior to the implementation of the Affordable Care Act, was about 10%. So in other words, we had a 90% unemployment rate for people receiving outpatient mental health services. Next poll. So what do you think is the homeless rate for people leaving an inpatient substance use treatment program? And this could be around the same time period is the data that we're kind of this research report that we're using as the basis for this. So this would be around the same time period, 2013, 2014.
We'll let this go for about another 10 seconds as well. Lots of variation here. Okay, I'm going to stop polling now.
So between the homeless rate for people leaving inpatient substance use, looking at 50% of folks thought it was 0 to 25, and 50% of folks thought it was between 61 and 100%. So it was actually almost 50% of people leaving a substance use treatment program became homeless. So this was a report, an evaluation report that research and data analysis did of people leaving institutional settings. So they looked at people leaving inpatient substance use treatment programs and people leaving the state hospitals, and found that almost 50% of people leaving substance use treatment programs were homeless within the year, and almost 30% of people leaving the state hospitals were homeless within the year. So the statistics like that, you know, a 90% unemployment rate, a 50% homeless rate for people leaving in inpatient substance use treatment settings, that really are some of the foundational components of why we looked at pursuing supportive housing and supported employment as a Medicaid reimbursable service in Washington state. There are a few other reasons why we laid that groundwork to create these new benefits in Washington state. Some of that was actually some legislative direction to look at outcomes and improve services using evidence-based practices. And so in 2013, the legislature passed Senate Bill 5732 and House Bill 1519 that required the healthcare system, the behavioral health system, and the long-term care system to start measuring outcomes. In particularly, the behavioral health system was charged with looking at employment and housing outcomes for our service delivery system. And there are actually dashboards on the research and data analysis website that show you how we're doing in these areas. I'm proud to say that our employment rate for the behavioral health population has improved, as has reducing homelessness. We still have a ways to go, but we are seeing improvements in those areas. We also were very fortunate to have two separate policy academies that were sponsored by SAMHSA and CMS and other federal agencies. And so teams of us came together and basically developed strategic plans to try and address chronic homelessness, as well as improve the employment rate for people with behavioral health conditions. One of those policy academies, the Chronic Homeless Policy Academy, actually, with SAMHSA's support, created a white paper on what if we had a dedicated service, a supportive housing service that could be tied in with housing subsidies, capital funding, in order to braid resources, Medicaid resources with state resources and federal resources, in order to really address the three legs of the stool around affordable housing and success with permanent supportive housing. That white paper propelled this idea of creating a supportive housing services benefit using Medicaid to pay for the services. In addition to that, as our state was going through what I call the hurricane of change, as we looked at integrating mental health and substance use treatment services into primary care through integrated managed care, that idea of that whole person care approach really started to emerge. And so the bill that actually created and launched integrated managed care actually gave us the statutory authority to implement supportive housing and supported employment services. And so that was actually Senate Bill 6312 that was passed in 2014. We also, as the Division of Behavioral Health and Recovery, have been building a lot of different foundational pieces, building the capacity of providers across the state to deliver these evidence-based practices. And so we've tried through different grants, such as the Porch Project, the Bridges Grant, the HARPS Project. Our best is Becoming Employed starts today, and we even did a TANF supported employment pilot. And so we were able to use these grant-funded programs to start trying these evidence-based practice services with different populations in different parts of the state, with different workforce using peers to deliver some of these services. And so that also helped inform the development of the supportive housing and supported employment services. And all of those reports and all of the fantastic research that RDA does is available on the website. And so all of the evaluations of these grant projects, all of these great research reports that really helped us form the business case on why we should have these dedicated services. Now the next step was, we just need a fund source to be able to do it. And that's really where champions such as Marianne Lindeblad, our Medicaid director, Jane Beyer, Chris Imhoff, our previous DBHR director, really championed the idea of, when the state was applying for the 1115 waiver, to include supportive housing and supported employment as a Medicaid benefit. So that's kind of the history of why we've come to where we're at with foundational community supports. We're also, just that really rudimentary information that employment is important to health. And I think that it's one of the social determinants of health that is less paid attention to. I think as a healthcare system, we haven't quite embraced that employment, equating employment with health. We still kind of think about others, that's another system's responsibility. But the Robert Wood Johnson Foundation came out with this information a couple of years ago and really started delving into looking at the negative impact that unemployment has, not only on physical health, but on mental health and substance usage. And so they put together these infographics and shared information. And so the next slide really starts looking at, when you are unemployed, of course, you lose your health insurance, so your access to health care is limited. But really, that unemployment leads to increased physical health issues such as increased blood pressure, cardiovascular disease, your diabetes is more likely to be out of control. You're more likely to use unhealthy coping behaviors, more likely to use alcohol more frequently, and you're more likely to increase depression. And so as a healthcare and behavioral health system, it's really imperative that we start thinking about the impacts that unemployment have on people's health. And that is one of the social determinants of health. Next slide. And of course, I think everyone embraces and understands unemployment or housing homelessness and the impact that homelessness has on people's health and behavioral health. Treating somebody for their chronic health conditions or their mental health or their substance use, and only to see that person released to homelessness, we know that the recidivism of that person and the likelihood of their path to recovery is going to be jeopardized if they don't have a healthy, safe place to lay their head. And so, certainly there's been a lot of research around this across the country. There's a lot of fantastic research around the Housing First model, both out of New York as well as our own state's organization, DESC. But really starting to, I think the healthcare system is really starting to embrace the notion that homelessness affects your health. And again, one of those social determinants of health. And so what we can do is actually now look at how do we provide the services to be able to help that person access housing and employment. And so that's really, again, part of the foundation or the cornerstone of what then came to foundational community supports. So I think we have another poll to say, have you heard of foundational community supports?
Yes, we do. Thank you everyone for participating. This one will probably go a little quicker. Go ahead and participate. We'll give it another 10 seconds or so. All right, I'm going to close the poll in just a few seconds. So get your answers in. I'm going to go ahead and close it now.
So 40% of folks have heard of foundational community supports. That's great. But 60% of folks have not heard of foundational community support. So we're very pleased to be able to share information with you about how to access these new services. And that's one of the reasons why my team is here today, is to also, if you have questions or want to have further information or presentations or linkages to the FCS program, my team can help you access more information and resources. So the Healthcare Authority and our partners applied for what's called an 1115 Medicaid waiver in 2015, in August of 2015. And what the waiver allows us to do is it allows us to use Medicaid funds innovatively in a demonstration-like program. But there's requirements that there be an evaluation, that there be cost budget neutrality, and that we essentially ultimately bend the Medicaid cost curve. So those are the kind of the elements. There originally were 3 initiatives of the waiver. Initiative 1 is the implementation of accountable communities of health. Initiative 2 is focused on the long-term care population and helping people age in place. And Initiative 3 is the development of supportive housing and supported employment services called foundational community supports. And so one of the things that we did in preparation for launching these services, so the application was submitted August of 2015. The waiver, CMS approved the waiver in January of 2017. But we actually did not launch FCS until January of 2018. And so we really tried to prepare the community, the state, for implementing these new Medicaid benefits. And so, as you can imagine, if you're familiar with behavioral health and what's been happening in the last couple of years in the healthcare system and the behavioral health system in particular, you know that there's been a lot of changes. And so one of those significant changes were the integration of behavioral health into managed care. And so with all of that happening, the decision was made by the governor's office to have FCS services be administered by a third-party administrator. And so the Healthcare Authority did a procurement, and Amerigroup, who happens to be one of the managed care organizations, won the contract to administer FCS. And so FCS can be provided to anybody in any of the 5 Apple Health plans, but there is a firewall kind of between Amerigroup as the MCO and Amerigroup as the third-party administrator. And so we've been working with Amerigroup over the last several years to create a very robust network, to create the services and the consistency of the services to follow the evidence-based practice models of supported employment and supportive housing. And so part of the team, our 4 trainers and Amerigroup and our sister state agencies, we've been working to prepare the workforce. So we know that there's workforce challenges. And when you create a specialty like supported employment and supportive housing, you really want to invest in that workforce by providing trainings and curriculums. And so one of the workforce that we really rely on and promote is having people with lived experience in housing, homelessness, lived experience with behavioral health conditions, to actually, they're so well equipped to help navigate resources and then I know what it's like to be in your shoes. And so we've actually been creating and promoting a lot of training to create a specialty workforce that really focuses on the nuances of supported employment and supportive housing. We also have been preparing agencies, and I oftentimes say that we're doing 2 demonstrations. We have 1 demonstration to implement these 2 new services. The second part of the demonstration is that we're using a non-traditional agencies to deliver the services. And so we have licensed community behavioral health agencies, we have federally qualified health services or centers, we have nonprofit organizations, we have housing providers, we even have a housing authority under contract. We have tribal organizations, tribal health organizations. So we have quite a wide array of non-traditional agencies that are delivering these Medicaid reimbursable services. And some of these organizations have never provided services under a Medicaid delivery system. And so some of that process, the early learning and what we've developed to create our robust network, is to educate them and train them on how to deliver Medicaid reimbursable services. So we've done that through Medicaid academies. And so that's that process of just what documentation you need to have in place, how authorizations work, how encounters work, and the documentation for those encounters. And so that's been a big part of the second part of that demonstration, is just using a non-traditional agency network of providers to deliver the services. We've also promoted a learning collaborative approach to the fidelity of the evidence-based practice. So we actually incentivize agencies to follow the evidence-based practice models. And so we have a learning collaborative approach. Agencies go on cross-agency fidelity reviews. So it's really been a great way to cross-pollinate and create the consistency for delivering the evidence-based practices. We've also received funding to help particularly substance use treatment agencies develop the capacity to deliver these services. What's really exciting is a lot of the substance use treatment agencies have never had access to these kind of services before. And so we actually have a number of seed grants that we've provided over the years to help organizations get started and have the capacity to deliver these really unique specialty services. We've also created a lot of partnerships with Department of Commerce for housing subsidies. So it's important, we can provide the services. What we can't do is pay for the housing or pay for the wages for somebody's employment. And so we develop partnerships with the Department of Commerce where they can have access to the rents, vocational rehabilitation, or work source for the wages, things like that. So we've developed a number of partnerships with other state agencies. We've developed a number of tools like our Pathways to Housing and our Pathways to Employment site. I believe these are hot links when you get the PowerPoint. And then most importantly, creating the network of providers. And so AmeriGroup has actually over 160 agencies under contract. Those 160 agencies represent almost 500 sites across Washington state. So we have services being delivered in every county across the state. Next slide. So what are these services? So supported employment is really about understanding what that person needs to be successful. And you'll notice that there's actually a lot of parallel characteristics between supported employment and supportive housing. When you look at the evidence-based practices and the principles behind each of these evidence-based practices, they're very similar. And so it's really that housing first and employment first philosophy. And so looking at making a match between an employer and an individual, and making a match between a landlord and an individual, and then supporting that person to maintain that employment and maintain that housing. And so these are kind of an array of what this services actually consist of. Next slide. So what these are services. What we can pay for the services to help somebody obtain and maintain housing and obtain and maintain employment. What we can't use these Medicaid funds for is subsidy money to pay rents or to pay wages. And it is unfortunately just for Medicaid enrolled individuals. Next slide. So who is eligible for foundational community supports? So of course, people have to be enrolled in Medicaid. For supportive housing, individuals must be 18 and up because they need to be able to sign a lease with a landlord. But for supported employment, individuals actually can be enrolled at 16 because you can work at 16. And so those are the age eligibility factors. And then for this is what we consider our medical necessity. There has to be a diagnosable need for why that person needs these supports. So whether it's due to a complex chronic health condition, a behavioral health condition, or a functional impairment, such as somebody with a traumatic brain injury or somebody receiving long-term care services through home and community services. So those are the foundational components for eligibility. And then on top of that, we really wanted to focus these specialty services on individuals that are most at risk, most vulnerable. And so the next slide really goes into then who are the target populations for these services. So for supportive housing, these are all ORs, so that individual must be chronically homeless or have frequent or lengthy stays in institutional settings, and that can be prisons or jails, or frequent stays in residential care stays, such as substance use treatment programs, mental health treatment programs, or somebody that may be involved in the home care system at home and community services, that their housing is in jeopardy because of the frequent turnover of in-home caregivers, or a predictive risk intelligence system this is an algorithm that was created by research and data analysis to identify those individuals on Medicaid that are most at risk of costing the Medicaid system more than the average person on Medicaid. And so the PRISM risk score of 1.5 or more. For supported employment, the eligibility, the target population are those individuals that are on the pathway towards long-term governmental benefit assistance. So individuals on housing and essential needs, that's our old general assistance program. An individual has a short-term incapacity, and that incapacity may lead to then that person moving towards age, blind, and disabled, or SSI, SSDI presumptive eligibility. And so those are folks that are on that pathway towards disability benefits. Or an individual that has difficulty or obtaining or maintaining employment due to their age or physical disabilities or traumatic brain injury. Somebody may be involved in the home long-term care system through home and community services, or an individual with a substance use disorder with multiple treatment episodes, or a person with serious mental illness, or somebody that has co-occurring serious mental illness and substance use disorder. So those are the kind of the target populations. And so we've been implementing these services now since January of 2018. We've enrolled about, I think we currently have about 6,000 people enrolled in the foundational community supports. And I think the next slide is starting to get into a little bit more about the evaluation. And I'm going to turn it over to Taylor to share information about our preliminary evaluation findings.
Great. Thanks, Melody. So hello, everyone. My name is Taylor Danielson, and I am a research manager with the Research and Data Analysis Division. We are housed within the Department of Social and Health Services, and we support our program partners at various agencies across the state with their work in providing services to clients and also in evaluating some of their programs to determine if the programs have been effective or not and have met their stated goals. We are a unique organization in that we house a number of different types of researchers that cut across disciplinary lines. So we have psychologists on board. We also have sociologists, health researchers, economists, programmers, database administrators, a lot of different types of talent represented at RDA. And we are also unique in that one of the things that we have done over the past several decades is worked with program partners and agency partners like the Healthcare Authority to develop what we call an integrated client database. And an integrated client database is governed by a number of different data share agreements that ensure that client data is protected, but then integrates this data together into a repository that we can use for research purposes. So what we have done is, using client identifiers, we've been able to link information across data systems and then assign them a common identifier we call our person link ID for the purposes of facilitating the types of research that we do, these evaluations and this ongoing support for agency partners. Melody has asked me to speak a little bit today about the preliminary evaluation findings. I want to note that a couple things about the evaluation and how it relates to the larger Medicaid transformation project. As Melody noted earlier on in this presentation, there is an independent external evaluator that is tasked with evaluating the effectiveness of the different types of interventions that have been implemented under the Medicaid Transformation Project. That is the Oregon Health Sciences University research team. It is not RDA. We are internal to the state. So while we can provide evaluations of services, we are not the final evaluator for the project. That is OHSU, and they're the ones who are submitting materials to CMS for review. The other thing I want to note about this slideshow in particular is that we are focusing our attention right now on the population that's served by the Healthcare Authority, but we did also do an evaluation of services that were provided to individuals being served through the Aging and Long-Term Services Administration. These are initial findings and they may change. So these evaluation results focus on individuals who enrolled in the program during the first 9 months that FCS services were offered, so between January of 2018 and September of 2018, which has been quite a bit of time has elapsed since then. And in some cases, the number of individuals enrolled in the programs were fairly small. So what we may see is some shift in the results as we build up the number of individuals enrolled in the services. I also want to note that the populations that we are looking at may have included individuals who transitioned over from existing grant programs. So Melody highlighted a couple we've worked together on in the past. One is Becoming Employed Starts Today, and the other is the TANF Supported Employment Pilot. The TANF Supported Employment Pilot actually ended in December of 2017, so we did have several of those clients transitioning to FCS. And then when FCS services came online, we did have some BEST clients also transition to FCS from the grant program. And so, yes, the next slide, with regard to the FCS study measures. So really quickly, a brief overview of our analytic approach. We use the integrated client database, the integrated administrative data that we have access to implement what we call a propensity score matching method, which is just simply what we're doing is using administrative data on individuals in the quote unquote treatment group. And then we're looking for other people who look like them as much as possible, but did not enroll in the treatment, to make comparisons across the two groups, to be able to say, holding everything else constant or making sure that the two groups are as similar as possible, we can say that the intervention or treatment had this effect. And what we did for this set of analyses is we identified FCS clients using administrative data, so enrollment data available in Provider 1, and I want to note that they may or may not have received a service. It's purely whether or not they were enrolled in FCS services. And we split them into 4 populations: ALTA clients who received supported employment and supportive housing services, and HCA clients who received supported employment or supportive housing services. And then what we did is we used a wide variety of measures to look for other clients who looked like them in the Medicaid population who met the FCS eligibility requirements that Melody was talking about earlier. So we looked at things like, what were their mental health diagnoses? Had they received psychotropic medication in the past? Or did they have some indication of a substance use disorder treatment need based on medical diagnoses, claims data, or arrest records? In the year prior to enrollment in the program, or for the comparison group, the index month, we looked at things like, were they employed? What was their chronic illness indicator score? Did they have involvement with the criminal justice system? Had they received other social services like basic food or TANF? And had they visited the emergency department, or had they been hospitalized? And were they homeless? And we also included some contextual level information on the area that they resided within, so local, county or block level, or excuse me, tract level unemployment rates, and things like that. And then we looked at their demographics, their household composition, et cetera, and we matched on all those different characteristics. And then what we did is we compared for the 6 months prior to the enrollment date and the 6 months following enrollment, or the index event for the comparison group, what their employment and earnings looked like for supported employment, how often they visited the emergency department, and received outpatient or inpatient services, and how many times they've been hospitalized in an inpatient setting, which includes psychiatric facilities. And then we looked in the 6 months following enrollment, we looked at those same outcomes, as well as whether or not they were housed in a Department of Commerce funded project. So something like a transitional housing, or supportive housing, permanent supportive housing, or permanent housing project. And then we also looked to see how many individuals were transitioning out of homelessness in the supportive housing population. And for the majority of these measures, where we had information from the pre-period and the post-period, what we did is we calculated what's called the difference in differences. So we subtracted the pre-period value from the post-period value for the treatment and control groups, and then looked at the difference between those two groups to see in the rate of change, to see how they differed over time. And that'll make a little bit more sense when we look at the charts in a couple of slides. Next slide, please. So summary of the key findings from this, the initial foray into these analyses is, on the supported employment side, we observe uniformly positive impacts on employment, earnings, and hours for both the healthcare authorities population and ALTA's population. The magnitude of the employment effects are relatively modest. By that I mean the earnings effects and the increase in hours worked were relatively small, but we did see some appreciable increases in the employment rate. And we did not observe any statistically significant impact of supported employment, enrollment in supported employment services on emergency department or inpatient hospitalizations. On the flip side, for supportive housing, we did see statistically significant or promising positive impacts of supportive housing, enrollment in supportive housing services on transitions out of homelessness for both the HCA and ALTA populations. So this is an individual appeared to be homeless based on administrative data in the post period, and then we saw them transition out of homelessness, so they no longer came into contact with the system or received housing services, or were homeless based on administrative data gathered by the Economic Services Administration, and they did not return to homelessness in that 6-month period. We saw promising reductions in ED utilization and inpatient hospitalizations for the HCA population. And then we didn't see any positive significant impact on ED utilization, inpatient hospitalizations, or nursing facility utilization for ALTA clients. I want to pause here for just a moment and say that, to clarify what I mean by promising findings, is a promising finding is something that is not statistically significant. It can approach statistical significance, meaning that it looks like it's not just occurring by random chance, and it's in the expected direction. So we are seeing something that looks, it's positive, and it's in the way we were hoping, or it is displaying what we were hoping to see. So we are seeing reductions in ED utilization would be an example of that. Next slide, please. So focusing first on the supported employment outcomes, when we look just at employment and earnings, and we're going to focus really on this piece of things, what we see is that the employment rates are pretty similar for the comparison group and supported employment clients. Actually, they're identical. And we see a slight increase in employment rates for the comparison group between the pre and the post period, but a 12 percentage point, or more than 12 percentage point increase in employment for the group that received supported employment services or were enrolled in supported employment services. And when we adjusted for any remaining differences between the treatment and comparison groups, what we see is a 12 percentage point increase in the employment rate for individuals enrolled in supported employment services. We also see a $329 increase in average earnings, and this includes individuals who were both employed and unemployed. And that was not statistically significant, but it was promising. It was close to statistical significance. And then we also saw a significant, statistically significant increase in the number of hours worked. So individuals who were enrolled in FCS supported employment services experienced an increase in their hours worked of about 36 hours on average once we adjusted for remaining differences between the treatment and control. Next slide, please. On the supportive housing outcomes side, we do see a reduction in outpatient ED visits between the pre and the post periods for individuals enrolled in supportive housing services. Although you can see here, there are some lingering differences in terms of their pre-period utilization patterns that suggest that there may need to be some improvement in the matching, and that this is not a statistically significant finding. That p-value of 0.14 indicates that it's not meeting that threshold to say, yes, this is a significant finding. But we do see a reduction, so it is promising to see that reduction in the ED utilization. And then on the inpatient hospitalization side, we do see that the two groups are more similar in terms of their pre-period utilization patterns, and that there is a decrease of 12.4 hospitalizations per 1,000 member months, which means folks who, for each month that somebody was enrolled in Medicaid, we would aggregate that up and then we would divide the total number of inpatient hospitalizations that occurred during a member month divided by the total number of member months to get, and then multiply that by 1,000 to get this rate. And we do see that decrease, and that is much closer to statistical significance. We typically use a benchmark of 0.05, and here it's 0.06. And one thing I want to highlight with these findings is that, as I noted earlier, OHSU is the independent external evaluator for the waiver, and they have recently released an interim report that is available on the Healthcare Authority's website. I would encourage you to go look at that. There are some areas of congruence between our two sets of analyses. OHSU also observed a significant increase in employment rates for FCS clients, and any remaining differences, we are in discussion with them about analytic approaches and how to improve both sets of analyses in the future. And we believe that we're going to be homing in on the same types of findings in future iterations of our analyses as we move forward. And that is it for me. So next slide.
Thank you.
That was the last slide. Thank you very much. I think we did provide another slide of some resources, and so maybe I'll just kind of highlight some of the resources that we provided. So, it's really exciting to see CMS coming out with guidance, more policy guidance on social determinants of health. In fact, the CMS policy paper that they just issued after the first of the year actually highlights the Foundational Community Supports Program. Excuse me. And there's certainly a lot more resources if you want to learn more about FCS, and I'll maybe pause and see if there's any questions.
Yeah, thank you so much to both of you for sharing your knowledge and the experiences you've had with FCS so far. We haven't received any questions yet, but I think Milena might have one. And then for the audience, please feel free to enter any question to the question and answer box and/or the chat box. We are looking at both. Milena, did you want to kick us off?
Yeah, sure. That was a great conversation, and I actually learned a lot today too. I am familiar with the FCS program and always learning more. I'm wondering if anybody could speak to the importance of, the research, right? I mean, I think we always tend to shy away from conversations about research. And yet, what I heard today is that research has a huge role in informing policy. And that's also why we study these programs and ask for data and information from folks. And so I wondered if we could talk a little bit about the role of research in informing policy and how that has helped the state create its waiver program.
This Melody, I'll take a stab, and then Taylor, if you want to jump into, it's kind of interesting that you say that, Melina, because the third prong of our Chronic Homeless Policy Academy strategic plan is to use data to drive decisions. And it was really the data that RDA has generated through their research reports that really laid the foundation for the FCS program. So the fact that people were coming out of institutional settings and becoming homeless at a very high rate, and using that data and the impacts of the costs of individuals that are chronically homeless on emergency room usage. And so the white paper that SAMHSA sponsored is largely based on data, and research and data analysis contributed a lot to that white paper, and really looking at the cost deciles of people that met chronic homeless criteria. And so we really have used data to drive decisions, and the research room, we're continuing to use data to drive decisions for program evaluation, if we need to make tweaks in the program. On the last slide, one of the links is the enrollment reports, and you can actually see on the Healthcare Authority, we've posted the enrollment reports that RDA generates for us. Just how, are we reaching those target populations that we said we were going to do, the eligibility of the target populations in the application. So are we reaching people that are chronically homeless? And I'm really proud to say that almost a third of people enrolled in Foundational Community Supports have met the chronic homeless definition. Are we reaching those folks that are on the pathway to dependence on long-term governmental benefits for supported employment? And I'm really proud to say that almost a third of individuals, or I think it's over a third of individuals enrolled in supported employment, are on housing and essential needs. And so we are not only using the data to make the case on why we need these services, but we're also using data to make sure that the program is doing what we said we're going to do. And then of course the evaluation is the fruit of the labor, really as sweet as we think it is. And that's why it's so important to have evaluation components as well.
Thank you, Melody. Taylor, do you have anything to add?
Sure, yeah, and thank you, Melody. I guess what I would say with regard to data and policy and how the two can inform one another is we would not be able to do the types of work that we do without program partners who are willing to work with us and provide not only guidance, but also just to have a willingness or demonstrate a willingness to listen to the types of things we're saying and be open to reviewing data with us. And this is something that I've always really appreciated about Melody and her FCS team, is that they are always, willing to have conversations about data and to gather the data. That's another really crucial aspect of this, is that the types of work that we do is so dependent on the quality of the data that is gathered by our agency partners. And that's especially true of small programs and small grant-funded pilots, where we really need the folks on the ground who are at the organizations providing the services to gather information, and we need to have that support from our agency partners to help make sure that we're getting good data. And we've always gotten that from our program partners. So it's been a very positive experience for us. And I would say on the subject of informing, using data to inform policy, like Melody said, there are a lot of just very foundational questions that we can ask that we should be asking, things like, what does the employment rate look like for individuals with a behavioral health need? And also, so those sorts of things are very helpful. I think we underestimate sometimes how helpful and useful they are. And I think, and then there's always the pilot programs, and being involved in those and being able to do initial evaluations of those projects and look at their effectiveness is a useful way for building up toward these statewide initiatives like we're seeing with FCS.
Thank you for that, Taylor. I mean, when we work in the grant-funded world, we do have to show proof of concept, right, to be able to scale and provide more of a service. And so congratulations on doing that and expanding the program. I had one other quick question, and this is really related to the comment I think that Melody, you said around the seed grants for SUD agencies to develop the capacity for FCS. I'm wondering if you could share a little bit more about that and how agencies might be able to access that if they are interested.
Yeah, so we actually, I think, just finished our first round, and I just want to go back to the data for one quick second. And one of the cool things that Matt Christie, the program administrator, is working on is not just looking at the outcomes, and he works really closely with RDA, but he's also looking at the average services per individual and services, the encounters that are happening by agencies. And so he's also, as the program administrator, is also using data for performance for the AmeriGroup, the third-party administrator. So we also ask AmeriGroup to look at outcomes. We have self-reported outcomes that the providers also submit. So we really are data rich. It's really just the time to analyze all of that and be able to generate that. But so I just wanted to highlight that in some of the work that Matt is doing. With regards to the seed grants, I am going to ask my trainers who are on the call to help me out here. So we did a round of seed grants just recently, kind of did an open procurement just for agencies that might be interested. I think it was an RFA, not a full RFP, but just ask which agencies might be interested in receiving these seed grant funds. And they can use the seed grants to implement supported employment or supportive housing. I think the seed grants were $30,000. That's to help hire staff. And then the trainers set up kind of a series of training events or orientations for those staff, for those agencies, to understand and embrace the evidence-based practice models. And then also with the outcome of the agency becoming a contractor of AmeriGroup. I also believe that for agencies that maybe large agencies that have multiple sites, I think that the seed grants could also be used to expand FCS services to additional regions or locations or sites. So I'll pause and see if any of my trainers are able to help me out and bail me out with make sure I've covered everything.
Kimberly, can you guys hear me?
Yep.
You did a great job. So yes, we are getting ready to do another round of RFAs. Hopefully it'll be happening again as soon as September. to be offering another round of agencies to be able to participate in this, in the SUD startup funds. We don't have the funds vary, so I'm not sure exactly how much we have for agencies, but we're really excited to get this going. So be looking for announcements coming forward for when that RFA starts.
Great.
And even if agencies, you know, if they want to get started and learn more about this, our trainers are available, and we can make sure that everybody's email address is in the chat, or all of their contacts. So the trainers do, I think, are 6 or 7 webinars a month, just to share resources, information about supportive housing, supported employment, or other programs that people can get linked to. I think there was one recently on fair housing, WorkSource. So there's lots of different programs that they highlight. But those webinars are available on our foundation's newsletter, and we'll put the link to the foundation's newsletter. We detail out all of the upcoming webinars for the month on our newsletter, and encourage everyone to get signed up for our newsletter. A lot of cool information through the newsletter.
Great, Melody. Yeah, if you could make sure I get that link, I'll make sure that it's included in the email that I send out later this week with your slides and the recordings. So I'll make sure that's included. So we are just at the top of the hour. I really want to thank Melody and Taylor and everyone who participated today and put effort into making this work available, and just really thank you for providing such a valuable value add to our communities. And hopefully more to come. We'll continue this conversation, and just really thank you so much.
Thank you guys for the opportunity. We appreciate it.
Absolutely.
Thank
All
you
right.
very much.
Have a wonderful day, everyone. Thank you.